James. He's on the hand service right now, so I can. We're going to get started this morning, and this is our third grand rounds of the year, and it's actually more of a normal grand rounds. We had dinner last night, so that was wonderful to finally get to do that again. And I'll have James introduce our esteemed guest speaker to this morning.
Thanks very much, Bobby. We are looking at our last grand rounds here in the long conference room as we move into our new building. Thanks to Winston for setting us up virtually. We've got a number of participants who will be joining us online as well. I think it's a fitting way to go out and leave this building where we've had numerous grand rounds with some of the biggest names in orthopedics come through over the last, 15 years, 20 years, Bobby, in this room. So it's, it's a big day for us as we transition to our new facility. And I'm honored to introduce Dr. Doug Dennis as our visiting professor. It's really an honor to bring Dr. Dennis to campus, to UVA. He's truly one of the living legends in orthopedics and a true giant in the field of joint replacement. He's coming to us, of course, from Denver, but he's really an Ohio guy, born and raised in Ohio, Bowling Green State University, Medical College of Ohio, and then Ohio State for residency. Following his fellowship, he started practice in 1985, and he's really witnessed the incredible coming of age of joint replacement. And he's really not just witnessed it, of course, he's really led all the revolutions and development and evolution in joint replacement. He's been really a true thought leader and has developed many of the concepts that we teach you today. He's done the research on knee kinematics. He's helped to develop the implants. And so, Dr. Dennis has really left an incredible legacy and made a huge impact on how we take care of patients. He's a prolific researcher. He's made incredibly valuable contributions to the literature. He has several academic appointments. He's an adjunct professor of biomedical engineering at the University of Tennessee, and he also has appointments at the University of Colorado School of Medicine and the University of Denver. He's a true servant leader, past president of AUKUS, past president of the Knee Society, and he's the executive director of Operation Walk in Denver. And I know that service and giving back has been a big part of his career as well. I think what's most impressive about Dr. Dennis is his character. He's really a family man, as you'll see. He's a man of integrity. He's a man that everybody trusts. And there's now generations of surgeons, I think, that look up to Dr. Dennis and have been inspired by him and what he's done during his career. Dr. Dennis is going to give us two talks today, one on spinopelvic issues and total hip arthroplasty, which is really probably the hot topic in total hip arthroplasty, and then a second talk about lessons learned during his career, which I think we'll all find very insightful. So without further ado, Dr. Dennis, thank you again for coming all the way from Denver. It took 3 planes to get you here, almost 2 hours of delay in the airport. And of course, it's 5 a.m. in Denver, and just getting back from Hawaii where it's 2 a.m. So thank you for making the sacrifice to be with us.
Well, number one, James, you're way too kind. I can't tell you what an honor it is for me to be here. All of you residents, are training at one of the finest, most highly esteemed academic institutions. And so when James asked me to come, it was really a privilege for me to go ahead and do so. Probably my most exciting thing that I have tried to learn and teach myself in the last 5 years is how the spine affects the hip and how the hip affects the spine. So my first presentation is entitled Understanding This Hip-Spine Relationship. And of my disclosures you show here, one is particularly important. I am a consultant with Corin, and some of the things that I'm going to show you as far as how I evaluate my patients, particularly I have a case presentation at the end, will involve some of their technology. So please put a filter, in front of that, because my academic reputation is very important to me. So I was taught, and my guess is Tom Brown and James and Trey were all taught to put the socket in the Lewinick safe zone. And this is based on an article in 1978 by Dr. Lewinnick out of Northwestern. And he looked at 300 total hip replacements. And he said, if you put the cup at 40 degrees of inclination, plus or minus 10, and 15 degrees of aneversion, plus or minus 10, you will have lower dislocation rates. And in his series, if it was in this zone, there was a fourfold lower dislocation, but 3 dislocations occurred with the cup within the Lewinnick safe zone. And this was a landmark article out of the Mayo Clinic. I believe it's 2016, because they took this article to task. And they looked at their registry of nearly 10,000 hip replacements. And I think their dislocation rate was 1.7%, so a low rate, but times 10,000, they had a cohort of dislocators. And 58% of those who dislocated had their hip exactly where Dr. Lewinnick said to put it. So what else is going on? And I think in the last 5 years, we're really starting to understand why these are. And Larry Dorr coined the functional safe zone rather than Lewinnick safe zone, where in the functional zone, the cup position is based individually on each patient's individual spinal pelvic mobility patterns. Well, why is this important? Let's look at this study by Jonathan Vigdorchak, where they looked at 117 revision hip replacements and they analyzed the cause of failure. And about half of them were avoidable revisions and the other half were not. But if you look at that sub-cohort of those that were avoidable, nearly half of those were associated with suboptimal cup position, the majority of which had abnormal spinal pelvic parameters. If we look at the latest 2021 American Joint Replacement Registry, hip instability is the #2 cause of revision. The year before, it was actually the #1. And in the Australian registry, again, the #1 cause of revision hip arthroplasty is instability. And if we actually look at the reasons for re-revision, instability is #1. So obviously, we've had all of these advances over the years to improve our polyethylene and cementless fixation and all those sort of things. But the dislocation issue has remained a problem. And I'm just going to show you, this is a case example, because in 2016 is when my antennae went up. This was getting on my radar of what's going on here. And this was a patient that was done by one of my partners 11 years prior. And 7 years post-op, and her hip did beautifully. 7 years post-op, she had an L1 to S1 fusion. And within a year, she was dislocating anteriorly, okay? And if you get rid of the constraining ring and just look at the position, I think you'd say, gee whiz, that's a pretty nicely done hip replacement. But now she is dislocating anteriorly, so my partner went ahead and treated her with a constrained liner. And within 3 months, this is what's happening. And this is right when I was getting to the point of starting to understand this. And I'm going to go back to this case a little bit later. So why do you need to consider the mobility at that lumbopelvic junction? It is now known that spine motion can drive the pelvis into functionally abnormal positions that are not predicted from a supine AP pelvis radiograph. James, how many hips have you done where you did all of your planning and your templating and everything off a supine AP pelvis? I promise you, I have done thousands of hips that way. But Lembeck and other authors have shown for every degree of sagittal plane pelvic tilt, there is a 0.7 to 0.8 degree change inversion. And as I will show you, if the pelvis is tilting posteriorly, inclination and aneversion go up. If it is tilting anteriorly, they both go down. And if we want to do a little mathematics here early in the morning, that computes that if you have a 13-degree change in pelvic tilt, you will have a 10-degree functional change in your anteversion. And sometimes that will push your safe zone or push your cup where it's not in the safe zone. So here is posterior tilt of 13 degrees. And can you see what that has done to the cup? The inclination angle has gone up and the anteversion has gone up. And I want to point out, because I'm going to emphasize this more, that's essentially, if we took an x-ray of that, what is that? That's an outlet view of the pelvis. Now look what happens to the cup when it tilts anteriorly 13 degrees. And there again, you see a reduction in both anteversion as well as inclination. And so if we compare these two, a pelvis tilted 13 degrees in extension versus 13 degrees in flexion, there's a 20-degree difference in anteversion. And it changes when you go ahead, when you are supine to standing. And if you just look at the images here, you can see when you stand, there is some more posterior pelvic tilt, which is good because it clears the anterior aspect of the hip to allow better flexion. And I have termed this, and I tell my fellows, and if there's anything that, you know, you take away, because this has taken me a long time to understand, but just simple little things. When you go ahead, I probably ought to stay on here. When you go ahead and see a pelvis that looks like an outlet view, that is an extended pelvis. So you know that patient has increased anteversion. So if you're doing your operation, and you know, we sometimes, well, should I antevert it a little more or a little less? If you've got one like this, you want to make sure you're on the lesser side than the higher side, because this patient, as you can see, has 21 degrees of posterior pelvic tilt and is at high risk for anterior dislocation. So what is the consequence of this? So if you have a pelvis that is tilting posteriorly, you will get posterior impingement. And these are the ones that are at risk for coming out the front. And if you have a forward flexing pelvis, you will get anterior impingement. And these are the ones that are at risk for coming out the back. And this particular pattern is what you see in a lot of the people that have very stiff lumbar spines. And I'll bring this up a little bit later, but if we look at Bobby, he's sitting here at about 90 degrees between upper torso and femur. So he has to bend 90 degrees. Well, that's a shared bend between lumbopelvic and the hip itself. And the ones that have stiff spines, fusion, their spines can't bend. So what happens? The whole pelvis has to go forward, and look at the change in orientation of those two cups. And Houston, we have more problems to add to this dilemma, because another article done by Victorchek is how accurate are we at the operating table? And you know, we think, boy, we've got that cup right at 40 and 20. Have you ever been in an operation that you did or your attendings did, and you're sure you had it at 40, 20, and then when you actually go ahead and measure the radiographs, you're at 52 and 10 or 30. That happens. And so they went ahead and looked at 100 total hips done in the lateral decubitus position, posterior approach, and they had rigid patient clamps to hold everything in good position. How accurate were they? The surgeon predicted anteversion error was greater than 5 degrees in 41% of the patients. So we are not highly accurate in the determination of pelvic position. And if you think of that patient that has a BMI of 38, And I think one of the true advantages of a direct anterior approach is that you are doing it supine. One of my fellows this year is from the Rothman Institute. They did anterolateral, but they do it supine. When you put them up into this position, particularly in a very obese patient, where is the pelvis in this mass of soft tissue? And so that goes ahead and leads to error. And to make matters worse, this study by Nishihara, they went ahead and showed that when we do the operation, the pelvis is moving around. So you may have it perfectly positioned to start, but using computer navigation, when they just dislocated the hip, 12 degrees of change in pelvic tilt. So using that little mathematical formula, just dislocating the hip functionally changed the anteversion nearly 10 degrees. And it's more than just prosthetic impingement, like neck rim impingement. You also need to think about bone impingement. And this is one of my big interests, because I am convinced that I've looked back at my dislocations, and my dislocation rates are higher in petite females. And in petite females, they have less offset. So the femur is not further away from the pelvis. And often I think their dislocations are related to bone impingement. And here you actually see a patient, and this is a three-dimensional reconstruction from the CAT scan with the patient in the flex seated position. And there is no bone impingement. But now let's go ahead and look at this patient. And you can see, if you look at the lower arrow, that is actually an anterior rim osteophyte. But if you look at the upper two, and this was a patient that had big exostoses, and is this a pointer here?
It won't do well.
Whoops, that's all right. We'll be good here. Let's get rid of that. But this was a patient that had a lot of exostoses on the anterior aspect of the trochanter that led to impingement. And this was a dislocating patient. So when you have these, you need to look for those osteophytes, remove them if necessary, but essentially you got to get the femur away from the pelvis. You've got to increase the offset. And as all of you know, in my early years, we didn't have all these lateralized high offset stems. So the old trick that we did, we'd cut the neck lower and we'd use a longer head neck assembly. And that was a poor man's way of increasing offset. But you can use lateralized femoral components, lateralized liners, and increase neck length to go ahead and get that. But again, you need to go ahead in those cases and put your antennae out looking for those patients, particularly if you're a posterior approacher, as I am, because these can be problematic. So what are the spinopelvic risk factors? And these have all been validated in numerous publications. And I think all of the residents, for my fellows, because I'll tell you, this I think is a tough subject. And so I've kind of built this file of spinopelvic articles, and I'm sure you all stayed up last night and read every one of them. I certainly don't expect you to do that. But if you are interested in this topic, I think it's, when you have your free reading time, they're all PDFs, and to pull these out. And I'll tell you, some of those articles in there, I think I've read 5 times because I didn't understand much of it the first time, and you learn more. But what are the risk factors? Number 1 is standing posterior pelvic tilt of more than 10 degrees. Negative numbers means posterior. And you don't have to have the sophisticated analysis system that I'm currently using. For that, all you have to do is get a standing lateral spinopelvic x-ray, and you can see how the pelvis is tilted. Number 2, a pelvic tilt change from the supine position to standing. And so if you go from supine to standing, the pelvis tilts more than 13 degrees posterior. That is a risk factor. Problem is, to get the supine pelvic tilt, you need a CAT scan. So that's a tougher one to get. Pelvic tilt change from standing to flex seated over 20 degrees. The stiff lumbar spine. If you have a patient with lumbar flexion less than 20 degrees, clearly associated with higher dislocation. And I don't know if there are any spine surgeons that are here, but they've talked for years about sagittal spine balance. And that is assessed by looking at the pelvic incidence and the standing lumbar lordosis. And I'll tell you what pelvic incidence is in a few minutes. And you want those two numbers to be very close to each other. And if you have a mismatch of over 20 degrees, you have an 8% dislocation rate. So here's another case example. This patient came to me and her main complaint is every time I tie my shoe, my hip clicks. And if you just focus just on the AP pelvis, if I had done this, I probably thought, gee whiz, I did pretty well on positioning the components. But you also see she has an L3 to the sacrum fusion. And so when she forward flexes, she gets 30 degrees of anterior pelvic tilt. And look, she's lost all of her anteversion. It's pretty easy to understand why her hip clicks. And I'm shocked she hasn't dislocated. And which way would she dislocate? Posterior, because her impingement is on the anterior side. And to all of you in the audience, I'm posing the question and the challenge to you. Are you going to put the cup in the same position for all of these three patients? Obviously, on your left is a pelvis extended 29 degrees. So is that patient going to be at risk for coming out the front or the back? The front. Okay, then you have a neutral. And if you actually look at the three-dimensional images, you can see how the socket is positioned totally differently in these three patients. I think this was one of the early landmark articles. And in the reading list that I gave you, you'll see a number of them. Jim Pierpont is a brilliant engineer who really formed his own little company with, I think, 2 or 3 other very bright engineers in Sydney, Australia, and developed computer algorithms to kind of determine ideal functional cup position. And at the bottom of that list, Professor Andrew Shimon, who is a professor in Melbourne and a very good friend of mine, and he has taught me so much. And they did a study where they looked at 1,500 patients that had a preoperative spinopelvic analysis, standing, flex-seated CT scan, and they analyzed the effect of pelvic tilt on three-dimensional acetabular component position, looking at the supine position, the standing position, and the flex-seated position. And they found in this cohort that 17% of patients had spinopelvic mobility patterns that would put them at risk for dislocation. And if they added in a 5-degree error, surgeon error in cup position, 51% of the patients were at risk. And if you actually look at their data, 11% were at risk in flexion. So they were the ones at risk for coming out the back, and about 6% had extension risk with posterior impingement, risk of coming out the front. And the most important thing you should learn from this slide, if you look at supine to flex seated and standing to flex seated, look how variable the patient cohorts are. And when I started to dive into this, I just got these spinal pelvic x-rays on my own on people that had stiff spines. And I have subsequently learned, and Professor Shimon said, whoa, 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 whoa. Some people are also at risk who have hypermobile spines. So a high variability. So what about your risk when you see a patient that's had a spine fusion? And Buckland, the surgeon, and Vigdorchek, the hip arthroplasty surgeon, looked at the Medicare database and a couple 100,000 patients. And the dislocation rate with no lumbar fusion was 1.55%. If they had a 1 to 2 level fusion, it doubled to nearly 3%. And if it was 3 to 7, nearly tripled to 4%. And this study, this was actually presented at ACUS. I moderated this session, and I think this is a very landmark paper. And Mayo Clinic looked at their registry, and they took out of that the groups that had lumbar fusions and matched them 2 to 1 with those that didn't. And their dislocation rates at a year, very similar to the Vigdorchek paper, 1.7%, but 3-fold higher if the patient had a preoperative lumbar fusion. And the increased risk of dislocation if it involved the sacrum. And the hazard ratio, if it involved the sacrum, was 4.5 increased risk. And if it was fused to the sacrum and at least 2 levels, a hazard ratio of 5.2. Recent article that's out of the European spine literature, a meta-analysis, over 28,000 total hips that had a preoperative fusion compared to about 1.5 million that didn't. Statistically higher dislocation rates in the fusion group, all-cause revision, and all complication rates in those. And this was a good article that Larry Dorr published, and that how spinopelvic imbalance is a cause in late dislocations. And he actually looked at a cohort of 20 patients that had late dislocations. And half of them came out the front, half of them came out the back. And 90% of both the anterior and posterior dislocators had abnormal spinopelvic dynamics. And this image has helped me understand, because if you look at the spine, pelvis, hip relationship, Larry described it as 2 hinges. A posterior hinge, which is the lumbopelvic mobility part, and the anterior hinge is the hip joint. And to go back to Bobby sitting there, if he is at 90 degrees, has normal hips and a normal lumbar spine, about 20 to 25 degrees of that 90 is occurring at the spine, and 60 to 65 degrees is occurring at the hip. And Larry pointed out, if one of those 2 hinges is stiff, the other has to compensate. And that is why these people that have very stiff spines, since the back can't move, the hip has to move more, which increases the risk of prosthetic impingement. This is a study that I presented at ACUS. It's recently been published. How many people have stiff spines, and how do we measure lumbar flexion? You measure from the superior end plate of S1 to the superior end plate of S1 in both standing and a flex seated position, and you measure the change in that angle. And by definition, the literature has agreed that a stiff lumbar spine is one that has 20 degrees or less of lumbar flexion. Well, in our study, because everybody sees metal and an instrumented fusion, and you think those are the only ones you have to worry about. Well, 81% of this large cohort that had lumbar flexion less than 20 degrees did not have a preoperative lumbar fusion. They essentially, as the radiograph on your right, they have a biologic fusion. And interestingly, only about a third that had an instrumented lumbar fusion, by this definition, had a stiff spine. So it's not just the instrumented lumbar fusion patients that are at risk. So if we look at our traditional preoperative assessments, we get a supine AP pelvis, femoral radiographs, cross table lateral. We measure our leg lengths with a tape measure or blocks. We measure our offset by a templating. Is a more sophisticated way of analysis needed? Well, this is an article that we just published. Dan Bracey and Vishal Hegde, who are my fellows, and Dan is at University of North Carolina, and Bishal's at Hopkins now. And they took on the accuracy of the cross-table lateral. And we all have used that to assess how did we do with our cup anteversion. And beware of the accuracy of the cross-table lateral. Because let's just think, as you're measuring that cross-table lateral, if the pelvis is tilted backwards or forwards, you're going to potentially get error. So essentially, what they did is we looked at patients with CAT scans and the cross-table lateral, did all the spinopelvic measurements, and found that 23% of these patients had greater than a 10-degree error on the cross-table lateral. And the majority of all of those had associated abnormalities in spinopelvic mobility. So the cross-table lateral was inaccurate over 10 degrees of error in nearly a quarter of patients. So can more sophisticated preoperative analysis lower instability? And so what do you measure? And I'll tell you, I still remember, I think it was maybe about 15 when Larry Dorr presented this to the members meeting of the Hip Society. And you see that little guy up there scratching his head. I tell you, the brightest names in hip arthroplasty surgeon were all doing that, not understanding what Larry was talking about. And I kind of think early on, you know, there were so many angles and it was very difficult to understand. And I give Jonathan Vigorchik a lot of credit. And, you know, in some of the ACUS James symposiums, you know, he's really tried to make this, how can we make this understandable for all of us? Well, if you just simply get a standing and a flex seated lateral, and then you can do your own measurements. And what do I measure? Well, you measure pelvic tilt from the ASIS to the pubic tubercle. You measure the sacral slope, which is the end plate of, sorry, that's a touch screen up there. I'm just finally realizing that. And your sacral slope is S1 end plate to the horizontal, and your pelvic incidence, you take the S1 end plate, bisect it at a 90 degree, and the other to the center of the femoral head. And actually, pelvic incidence is something that is reflective of the width of the pelvis, and it does not change with positional change. Well, what is sagittal spine balance? I mean, essentially, and this is a hip or a spine surgeon thing, you want the head centered over the pelvis and centered over the ankle, okay? And again, ideally you want your standing lumbar lordosis angle to be very close to your pelvic incidence. And if there is greater than a 10-degree mismatch, by definition, this is sagittal spine deformity. And if the PI minus the standing lumbar lordosis is 20 degrees or more, these are your severe flat back patients. And based on the article by Del Sol and Vigorchik, that cohort had an 8% dislocation rate. So here, if you look on your left, is a balanced spine. And here you can see the difference between the pelvic incidence and the lumbar lordosis is only 1 degree. But the one on the right is the danger zone. And here you can see a mismatch of 22 degrees. And these are the patients that have that 8% dislocation rate. Now I'm going to share with you one of my patients. And this was a 52-year-old female presented to me with disabling pain of her hip. As you can see, she has advanced osteoarthritis of her right hip. She had had a previous L4, L5 instrumented fusion. So I went ahead and in July of 2016 did her hip replacement. And I thought I did a pretty good job. And I now know more that cross-table lateral may not be as good as what I thought. But she did well for 3 years, and her back really started becoming much more bothersome. She had a progressive slip above her fusion at L3, L4. She was getting radicular pain. And now she starts to dislocate. And she had documented dislocations both out the front and out the back. And again, now it's 2019, I'm understanding this, and I put so much time because I'm going to revise her, but what do? Where do I put her cup? She's coming out the front and coming out the back. And here is her spinopelvic analysis. She has 24 degrees of posterior pelvic tilt in the standing position, and her PI minus standing lumbar lordosis is 27 degrees. So again, these are big time risk factors for dislocation. And I use this little graph here, and it's based out of data out of Sydney, Australia, where they looked at a large cohort, and a lot of them were ceramic hips that had squeaking, believed to be associated with impingement. And if you look here, here was her supine orientation, here's her standing orientation, and when she's flex seated, her inclination angle changes 15, and her anteversion increases 15. And ideally, you like all three of these to be within this window. So I use that, and I said, well, I'm gonna try to put her cup at 35 degrees of abduction and 26 degrees of anteversion, and that puts her into that safer zone. And again, owl eye pelvis, you can see that. You don't need all this sophisticated things to know that she's got a posteriorly extended pelvis. So I did a dual mobility. I used computer navigation to make sure that I actually hit the target and put her at that orientation, and she's 2 years out, and so far so good, but I'm still kind of holding my breath on her. So should all patients have a preoperative evaluation? Well, early in my journey on spinopelvic analysis, I didn't think that was necessary. I now feel totally different, and Andrew Shimon, James, has really affected me and showed me cases where I wouldn't have predicted, and they had some pretty abnormal things. And if you go back to that article, and let's just look at sacral slope. On average, it's 42 degrees. But look at the range, -5 to 85, a 90-degree range. And in every one of these parameters, there are wide variations from patient to patient. This was a study I was glad to be part of. Hutch Huddleston presented this at ACUS, and they looked at 48 total hips that had dislocated, had at least one dislocation, and did a spinopelvic evaluation that I've already discussed with you. And they compared this with a non-dislocating total hip cohort. And on average, in all of these dislocators, their cup was at 43/23. So on average, pretty good. 71% of those who dislocated had their cup positioned exactly where Dr. Lewinnick said to put it, versus much less in the non-dislocating. As far as abnormal pelvic mobility patterns present in half of the dislocators, a fourfold higher than in the control group that didn't dislocate. And 75% in the dislocating cohort had one of those spinal pelvic risk factors that I have discussed with you, versus only 18% in the non-dislocating cohort. So what do I think the future? I think it's a preoperative pelvic mobility analysis to try to determine each patient's individual cup position. But if I can't hit that target, all of that information is useless. And if we go ahead and look at this article, heavily quoted, Callanan out of Harvard. Harvard has been a mecca of total hip replacement for 40 years. They looked at 1,800 of hips done by Harvard surgeons, and how often did they precisely hit both the inclination and anteversion targets? Only half the time. And there are better ways to help us hit the target. You can use patient-specific instruments, robotics, computer navigation, and I think we're going to be seeing in the future where we're going to be putting our little goggles on and using augmented reality to help us hit that desired target. Well, it's equally important in revision cases. And if we look at the Rothman Institute, they did 156 revisions for total hip instability, and 21% dislocated after the surgery. And if you actually, I think the article was Wu and Mori back in the 80s out of Mayo Clinic, a third of people that they operated on for instability dislocated again. And again, I think those numbers should be dramatically reduced if you do a pelvic analysis. And again, this is going back to that case that went ahead and dislocated. And I told my partner in my early journey, I said, I think you have to go back and revise this cup and take out anaversion. And that is exactly what he did, brought her down to about 10 degrees of anaversion, and she's lived happily ever after. I now routinely perform preoperative spinopelvic analyses on pretty much all of my revisions if I'm looking at revising the acetabulum. And because if you think, you look at the x-ray, that supine AP pelvis, cup looks great, dislocating, I'll solve this. I'm going to go ahead and put in a larger head, do a liner and head exchange, maybe lengthen a little bit. And I've done that a ton throughout my career. Most of the time, it is okay. But I now look at that totally different, because I want to know if I'm going to do a cup or if I'm going to do a head and liner exchange, that cup is in a good functional position. And I also relate, my theory is many of the failed constrained liners, because I have a number of patients with constrained liners out to 15 years doing just fine. And why? Because they probably had their cup in a good functional position based on their spine. Whereas the one that failed, like you showed, do not. So I am changing more cups in people that have chronic instability than I ever did before. And if I'm going to put in a constrained liner, I want to make sure their cup is in a good functional position to do that. This is a study, does it make a difference? And Professor Shimon extracted 1,728 patients out of the Australian Joint Replacement Registry that had had a thorough spinopelvic analysis with the spinopelvic laterals and the CT scans. 59% done posterior, 41% direct anterior. And at 3 years, there was a 1% revision incidence, but the majority of the revisions were not for dislocation. So in this group that had a preoperative analysis, the dislocation rate was 0.17%. And I was part of this study where we looked at 1,500 consecutive that had this type of technology, measuring all the angles. And we compared the desired functional position versus the Lewinick safe zone. And the take-home message, the dislocation incidence, was 0.4% with all of this analysis. And if we look at George Grammatopoulos, and they looked at 60 total hips with a spinal fusion versus 60 that don't. They looked at PROMs, they looked at all the radiographs. And again, the fusion group had inferior clinical outcomes, increased complications, including dislocation. This is a study out of Iowa from John Callahan, and they looked at how they were doing in their hip replacements that had a preoperative fusion. And they also looked at the Humana National Database. And they, as you can see in the title, abnormally high dislocations. At the University of Iowa, people that had fusions had a 20% dislocation rate, and in the large national database, it's 8.3%. So now what I'd like to do is just close, and this is a case that I did, and to go and the system I use, which I can move the pelvis, it's all web-based, and technologically sometimes I didn't know if I could bring it in, so I have narrated this. But this is a patient that I have done. She is a petite female, that I think I did everything hunky-dory and she dislocated.
I think she's fine, works again.
Okay.
I'm messing up my change. Sorry about that. It shouldn't be. Apologies. Should have-
You gotta hit a second time to get it.
This is an 80-year-old female who presented to me with the same advanced osteoarthritis. I do with all of my hip replacements. I gave pre-operative spinal health analysis for pre-operative. We actually look at her level of pelvic mobility patterns and see if she is at risk. She goes from standing to seated. She has pelvic tilt.
So she's a forward flexor, 21 degrees.
I have originally placed her cup in the lytic safe zone at 40 degrees. While with the cup in the lytic safe zone, you can look at her lumbo-pelvic dynamics, and you can see in red there's obvious impingement of the femoral neck on the anterosuperior lip of the acetabulum.
And this is all pre-op, so now I get to change things.
So obviously, in my mind, I need to go ahead and try to get rid of that constant impingement. I'm going to start by trying to change orientation of the cup, try to give her some additional anteversion.
And you can see the red patch is getting less.
And I certainly lessen the impingement, but it's still there. So I'm going to go ahead and work a bit on increasing her inclination. And so when I am in about a 45 degree 20 position, I now have a cut width of all of my prosthetic.
Okay, so I get this all figured out, right? So here is her total hip, and I thought I did really well, and I definitely hit the targets. In this system, I use patient-specific guides to hit the target, so I did all that. So boy, she's going to do great. Well, she suffered 2 early dislocations, both posterior, putting on her shoes, getting off the commode, both reduced closed. So in that era, this system provided me prosthetic impingement, and while it had bone impingement in Europe and in Australia, we didn't have it until I think it was February of this year. So I went back and because now I could go back and re-look at her preoperative analysis. So no prosthetic impingement, but she has bone impingement. And as you flex it, you can see those exostoses on the anterior aspect of her greater trochanter. And I'm going to stop that there just for a moment because, so what was I going to do at that time? Well, I have a chronic dislocator I'm going to operate. I know my functional cup position's good, so what? What would?
Decrease offset lateralizer and doing this ostectomy.
Yep. But what do a lot of doctors do in chronic dislocators? Yeah, dual mobility. And that's what I thought. I got that one figured out. So we're gonna go ahead and so I used all these different combinations and I assessed, and then I could look at it on the computer screen, and it was amazing how what I was feeling is what I was seeing. So again, the dual mobility has brought the femur 2 millimeters closer. So here you can see dual mobility has actually made my bone impingement worse. So now I've gone to a lateralized liner and I have lengthened her 5 millimeters. And if we actually look here, you can see now I have increased her offset by 5, and I've also lengthened her. And that's something that I was willing to accept. And the take-home message is, with a lateralized liner and lengthening her head, I no longer had any bone impingement. So, and that's what I did, and we lived happily ever after. But remember, in the old days of bipolar acetabular components, the bipolar cup would shift vertical. And that's not a good thing. And so that was because the center was right, the center of rotation was right in the center of the cup. And as soon as you medialize that center of rotation, it stays up here. But with that medialization, and I cannot tell you that every dual mobility on the market, but I have checked out 3 of them. And they have that medialization of the center of rotation. So if you have a bone impinger, and I mean, James, this is something that we're not hearing out there much. And the downside for me to get this information on bone impingement, I have to have a CAT scan. And where do I think the future needs to go? 2D to 3D registration. You can get 3-dimensional bone models from ultrasound, your augmented reality, all those sort of things. But I am convinced that, and it'd be interesting for the arthroplasty surgeons is to go back and just look at your dislocations. And at least in my practice, there is a propensity in the petite female and in people that have less offset. So that is my thought there. So Exact cuff target position is variable due to differences in functional pelvic position. I think the Lewinick safe zone is outdated. There are numerous risk factors that have now been identified. I think traditional pre-op methods are okay for many, but not good enough for all subjects. And again, I hopefully have got across how important I think that is. And I always like to close my talk showing off my granddaughter. This is our youngest one, Lila, who's our hellion of the group. So with that, I'll open up the floor to questions.
So here's a question from the audience. So Frank, see if you can speak out loud, we can hear you.
Yeah, thanks, Winston. Dr. Dennis, can you hear me okay?
I can.
Hey, thanks. That was a wonderful talk. I'm one of the spine surgeons here at UVA, and I really like the fact that I get to hear joint surgeons say the word spinopelvic a lot. That makes spine surgeons happy. So, besides understanding that if we get pseudarthroses in the spine, that's protecting your hip joint, what should we be doing as spine surgeons for our patients, telling them beforehand if they have bone on bone? We have the same conversations about what's hurting more, the spine or the hip. But we've understand from you and the joint surgeons that we're affecting your potential outcomes. But other than just telling our patients that it could affect them, what should we be talking to them about, and what should we be talking to joint surgeons about pre-operatively?
Yeah, I'll tell you that. I've been asked that question a number of times. I'm not sure I have a really good answer because so many of our patients with bad hips have bad spines. And I mean, the way I typically, because which one should you do first? And in general, the way I've handled it, if the patient has flaming radicular pain, they've got EHL weakness or neurologic change, I think the spine should be done first. And it may be better for me to react to what you do because, you know, obviously you certainly want to avoid the flat back instrumented fusions. And I think that is something that went away 10 years ago. I see our spine surgeons are, you know, duplicating that lumbar lordosis. But I think you should, you know, really work on trying to avoid, you know, a flat back spine fusion. And it really brings the question, you know, should the spine be done first? Then I can analyze what that patient's mobility is. Because again, if you remember, and looking at that group of over 6,000, only a third with an instrumented lumbar fusion actually had a stiff spine. And a number of those that had only 1 to 2 level fusions. It didn't involve the sacrum. Advice to you, if you're debating, do I need to go to the sacrum or not? I think going to the sacrum really ups the ante for dislocation. If you can avoid fusing to the sacrum, that's probably a good thing. Fewer levels is better than more levels. And but I now do dual mobilities on my high risk primaries. So if you look at those 5 risk factors, I've just kind of arbitrarily, if they have 2 of those 5 factors, I'm going ahead and doing a dual mobility primarily. And, you know, dual mobilities have their own set of complications. I did a cost analysis. I think at my hospital, it's $1,500 to $2,500 more for a dual mobility. And because there are some surgeons that I think at this year's Academy, at one of the instructional course lectures, they gave or maybe it was Hip Society, about doing dual mobilities on everybody. And I don't think that's a good thing to do. But, you know, if you know these risk factors, you know, dual mobility primarily.
Yeah.
So that's a kind of a long answer to your question, but
no, it was helpful because that's the sense I've been getting talking with our partners and with others, is that we might be hurting you more if you do a joint and then we lock the pelvis in a position that was significantly different than pre-op. Also, sometimes I hear the ability for patients to rehab well, just from a functional standpoint, if they have a bad spine, can be hard after hip and knee, whereas for rehab for spine, we just kind of want them to walk. We don't really need them to do a lot of intensive inpatient rehab and post-op. So I've been leaning towards, one, avoiding any spine fusion surgery at all, but if so, letting them know that there's always some challenges, but probably moving forward with the spine before the joints. And that seems to be the sense I get as well, but I appreciate what you said. It's helpful for me.
But as you know, there's still going to be the cohort of patients that have had their hip done when their spines weren't that bothersome. So you obviously don't want to prophylactically fuse those people.
Yes.
And but and to the residents and the fellows is, I think it's also important, knowing all this, to make sure that the modular acetabular component that you choose has a dual mobility option. So that if you do one, and let's say, for example, that case I showed 11 years before, there was not a dual mobility option for that cup. But today, I think you want to use that so that if in 8 years that patient needs a fusion and does start to dislocate, you have that dual mobility modular exchange option. And not all of the cups that are out there have a modular dual mobility option. So,
Thank you so much.
So I think Dr. Austin-Zada has a question.
Yeah, hi. I don't know if you can hear me. Dr. Dennis, great talk. Okay, fantastic. So as you said, we as a spine surgeon dealing with this problem a little bit longer. So one of the things we realized now in the last 5 to 10 years is that these numbers, these alignments is not equal for everyone. And a good alignment for a young patient is not a good alignment for middle age. And a good alignment for middle age is not for elderly patient. Do you see the same problem? We tend to have the change of the center of gravity tend to change with age, and overcorrecting them even within 10 degrees could be very bad for some elderly patients. Do you see the same problem in the hip? And the other question I have is the SI joint issue. It's SI joint fusion gaining a lot of popularity among pain management and spine surgeons. And I think there's more and more literature coming out that effect of SI joint fusion on a hip joint is more than we actually appreciate these days. Wondering if you've seen that already in the registry, a bigger number in joint patients.
I have not read anything like on isolated SI joint fusions and the effect on hip replacement. So I can't comment on that, but the reason we're not going to eliminate all dislocations is, so I'm going to do a 40-year-old, maybe had a dysplastic hip and do it at a very young age that maybe has a normal spine. And I do all of this analysis. So I put it right where it ought to be. But at age 60, maybe where we put it isn't going to be ideal. So again, another reason, make sure the acetabular component system, and I have a partner that, because the cup I use does not have a constrained option, and he won't use it because he wants one that has a dual mobility option as well as a constrained option. So for all your residents, when you're going out and deciding, what implant systems you're going to use, you need to not just choose because the rep's a really good guy that gives you good service. You need to look at what options, because, the spine dynamics are going to change, as people age. And, but I think the spine surgeons have really improved their techniques. I mean, I don't see many instrumented fusions walk in my office that have a flat back. 15 years ago, you did. So, other questions? Yeah, Tom.
That was a great talk. Just want to comment that's I think underappreciated is the stiff spine and the flexible hips. I think a lot of hips are not in that functional good zone based on their particular spinal pelvic mobility. But their hips are so stiff that they don't ever get to the position that they can actually impinge and come out. So the ones that worry me is when you're prepping somebody and you've got an elaborate position, they've got 90 degrees of abduction, a tremendous amount of rotation forehand, which also goes along with female. Often they are more ligamentaously lax than a bulky male that you can barely turn the foot 40 degrees. Can you keep them up straight because they're rolling in that position? You got a much bigger sweet spot for those people than we do for someone that has a lot of mobility in the hip joint and no mobility in their lumbopelvic junction. So that's why I think the femoral neck fractures are so worrisome, because they have so much range to impingement. It's much tighter. So
Couldn't agree with you more. And you know, how many of you have seen a patient that has a bad hip and bad spine, and you do their hip and they say, geez, you know, my back's feeling better. And I used to think it's because, well, their hip made them limp. And we know limp aggravates, you know, the spine. But I don't think that was probably right. Is, again, if you look at those two hinges, if the hip is stiff, much more load is transmitted to that arthritic stiff spine. And if you restore mobility to the hip, there's less torque on that.
One more, so I have a question.
Yep.
So you're a designing surgeon. So should we be working on, or is it being worked on now, to create a lateralized dual mobility option to solve some of the issues you're talking about? To increase the jump distance, but also avoid the impingement. Because my concern with dual mobility as being the blanket cover is that we're going to, in 10 years, we're going to have a bunch of broken stems from an impinging, notch sensitivity. Titanium is going to pop, and we're going to have a lot of femoral revisions that are unnecessary because we basically kick the can down the road a little bit. We really haven't solved the problem.
You know, that's a good provocative question. I don't know of anybody that is working on that. And you know, when are you going to put in most of your dual mobilities? It's in a revision. And you know, there's a downside to lateralization. And, you know, we get away with it with these cementless stems because the fixation is so robust. But in the old era, with cemented stems, if you increased it too much, it greatly increased the rotational torque on that interface. But remember, out and up dramatically increases the joint reaction force on the hip. So let's say, you know, you have a 3A defect and it's already migrated up, and then you're going to do that and bring it out. There might be a price to pay on the wear of the bearing. So those are kind of pros and cons that I see to that.
I want to make sure we have time for your next talk. So maybe we can ask questions afterwards. Dre, I got a few for you as well. But I think just in the interest of time, we've got some residents and fellows who are going to have to leave for clinical duties. Truly a fantastic talk, Doug. I've seen a number of talks on that issue, and that's as good as it gets. So thank you for that.
Well, you know, I continue to build, you know, that talk, and because I'm learning. And you know, I did not mention one thing about coronal plane motion or torsional motion. And Jean-Yves Lazenac. And in the reading list that I gave you, and it'll give you a headache reading the article, it's Hip International 2007. And that was the article that I've read 5 times. But he gave a lecture at AEOS, and you know, that little picture of this, I mean, he's talking about what happens in coronal plane deformity. And as for the fellows last night, Connor and Wells, you guys are going to be the next Charlie, and you're going to figure out all of this stuff. Because how do we, when you get that patient with rotatory scoliosis, or, you know. Okay, so this is actually a lecture that I've modified a bit, but Nicole, you'll hear it the last few days of your fellowship, because I've kind of addressed this to my fellows. And the title of that is Up, Up, and Away, because you're getting ready to leave. But I entitled this Career Tips 20 pearls I've learned from 35 years as an orthopedic surgeon. Well, when you are ready to take off in your own practice, there's different ways to take off. You can take off really fast, or you can go the balloon approach. And pearl number 1 is start out small or slow, avoid crashes. And what does that mean? That means extra time spent in your case preparation. And always remember that case quality is much more important than the quantity of cases you are doing. And because when you are new in practice, like somebody that's been in this town as long as Tom Brown has been in this town, I always used to say Tom Mallory could probably put the cup in upside down and have a complication, but it wouldn't hurt his practice because his reputation was so built. And when you are new in your community, you want success. You need to learn you need to earn the respect of all your scrub teams and all those sort of things. Pearl number 2 is find a good mentor, and both a mentor inside and outside of orthopedics to provide guidance in the tough times, help you with your career decisions. You know, with our fellows, our last journal club was totally on career decisions because they're all at the time when they're interviewing for their jobs and talking about contracts and is this a good deal or those sort of things. So you need good mentors. And you need to really find a good one, somebody like James. And I tried to dig up some dirty photographs or funny ones, and gosh, I couldn't find any. This guy is so perfect. But that, I bet you it did. You see the grapes in the background there. So, but if you look at those 3 people, they are 3 of the next leaders of joint arthroplasty. Choose good implants. And I recommend that you start with the implants that you've trained with, because again, early success is critical for long-term development. And don't join the implant of the month club. And I have one fellow that practices in Denver who has been a implant of the month club, and I'm not proud of the work he's done in our community. Pearl number 4. Utilize your senior partners. Gray hair is often associated with wisdom. On those tough cases, don't hesitate to ask them to scrub with you. Don't let your ego get in the way, because all of you are getting great training here. And yes, you know how to do these tough ones, but when you're early in your practice and when you're looking for jobs, you want to look for someone who's going to help mentor you. And it's that custom, it's going to be your first custom tri-flange or your first cup cage, to go ahead and have people that have been there a number of times at your side is a wise thing. Pearl number 5 is be humble. And I think, at least as an orthopedic surgeon, it's very analogous to skiing. And I live in Colorado. And, you know, I think I'm getting pretty hot. And all you got to do is go on that one run that's this much better than you, and you get humbled. And you have chosen a thrilling, a rewarding, but a very challenging occupation. And I promise you, and you can ask all of your senior mentors here, the more that you know, the more that you really realize you don't yet know. And the young, cocky surgeon is doomed to many failures. Pearl number 6 is give back to your field. Think of what you have been given by your mentors here, John Charnley, John Insull, and think of what they've given you. And you're going to do all these total hips, and they're going to give you a hug, and they're going to say, "You've given me my life back." Well, you better thank John Charnley for that, and your mentors. And for these treasures that they have given, I hope all of you feel an obligation to study and give back to your field. And I've always said, you know, I'm probably not smart enough, but I don't want to steal from my field. I want to try to give something back to it. Keep track of your data, even if you don't want to do research, even, you know, if you're not going to publish, because self-assessment is critical, and you must be your most severest critic. And as we have all known, nothing ruins results like data. And often in my practice, when, you know, I'll go to my research coordinator and say, hey, could you look up my infection rate the last 5 years or my dislocation rate the last 5 years? And sometimes I was not doing as well as I thought, and other times I was actually doing better than I thought. But if you do not go ahead and collect your own data, you truly will not know where you stand. Pearl number 8, be good to your family. And for me, it's always a juggling act. I really want to be a good dad. I really now want to be a good grandpa. I want to be a good husband, and I want to be a good surgeon. And I find that sometimes I'm hitting home runs in a couple of those categories, in the others that I'm not. You also need to know what will get you out of the doghouse with your spouse. And could be flowers, jewelry, weekend at the Broadmoor. I've used that a few times. That's been a good thing for me. And to the spouses, you know, they need to learn that a surgeon's life is not often his or her own, and extra patience at times is required. And as far as when you have children, you know, in my experience, I probably could not give the quantity of time as a physician as others, but I truly think one-on-one time often trumps quantity time, where you may do that and you're distracted, but really focus on one-on-one time. A lot of the traveling I've done over the years when my kids were younger, if it was a meeting, one in St. Louis, and I was only on the podium in the morning, and in the afternoon took my son with me, so we got to go up in the arch, you know, things like that. Quality one-on-one time. Sometimes I went ahead, and due to that 3:30 soccer game, I stopped work and I went ahead and went and watched my kids play soccer and went back and did 2 more cases. Another thing you need to, we talked last night about the economics of orthopedics and how you need to be efficient. And one thing that I did for years, my kids have left now, home obviously, they're 40 and 37, but I would go ahead and I stayed late every Tuesday night until midnight. If you're ever in your office, there's nobody else there with you. It is peace, quiet. I got so much work, whether it's catching up on chart dictations, working on your research, whatever. And I did that every Tuesday night. So the other nights I could be home and have dinner with my children. Pearl number 9, always strive for perfection. You rarely get it if you do not strive for perfection. And always remember that precision trumps surgical speed. And I see a lot of young surgeons and their testosterone, I'm being too gender insensitive, but maybe their estrogen levels and their testosterone levels are so high, and how many cases they do in the day is how they judge themselves as a surgeon. Don't do that. And don't ever think you can. Every one of you sitting in this room are blessed. You're extremely well educated at one of the finest academic institutions in the country. And Wells, why can't you be the next John Insall? Somebody's got to do it. Connor, why can't it be you? And don't think you can't. And Thomas Mallory, who is my mentor, and I cannot tell you how he passed a couple of years ago, still affects how I think. And not just at the operating table, but in every aspect of my life. And there were the Malloryisms. And one of it, you never get to the moon unless you hop in the spaceship first. And I'll tell you, I believe that. And I encourage you to believe in yourself and don't ever think you can't. I told a story last night that I took a circuitous route to medical school, having an injury to my knee, and the orthopedic surgeon took me under the wing. And while I was a good student, I didn't think I could ever get into medicine. I've had a pretty nice career, but yet I was afraid to get in the spaceship. Don't be that. Pearl number 11, give back for all you have been given. And this is my favorite Bible passage, and it's Luke 12. And my PA had an iron worker carve this out. And Nicole, you will see it in my office, and my desk faces it every day. Can't hang it, it's so damn heavy. And but it's to whom a lot has been given, a lot is expected. Don't steal from your field. All of you have been given a lot. Work to try to give back. Pearl number 11, search out a great supporting staff. And I will tell you, through my 35 years, this has been the first 15 years, I had a great PA and my medical assistant wasn't so good, or my nurse was whatever. And here are my three key people. Peggy on the left is my nurse, has been with me 33 years. Jim, my PA, 25 years, and Francesca, 15 years. And when you find those people, take good care of them. And you may be at academic centers, or now I'm an employed physician. I don't have all the freedom I can't say, hey, I just want to write a check out of my practice to help them. But boy, I'll tell you, at Christmas time, those are good times where you can go ahead and do it. I'm helping pay the tuition for my PA's children at one of the premier high schools. And when you find those people, you take good care of them, because you have no idea how those people work to make my life easier. And honor your mentors. Here is my mentor, the late Dr. Matt Clayton above and Thomas Mallory below. They have given you a lot of education and wisdom, and I think you should honor them. And Nicole, you will hear about the Gray Beauty. And the Gray Beauty is a 5/8 inch curved osteotome. And Tom Mallory called it the Gray Beauty. And you will call it the Gray Beauty, just as I call it the Gray Beauty. And that's just one little way that I am honoring Tom. And gosh, how I would love to talk to him, one more time. Pearl number 13, be a lifelong researcher. If you're doing joint replacement, it remains fun after over 30 years for me and over 12,000 total joints. But it's not quite as exciting as it was the first 10 years. And why am I still working? It's because I can't wait to educate Nicole next year. I get much more satisfaction and intellectual stimulation by teaching and those sort of things. And I've seen so many orthopedic surgeons that hit age 50 and they're stale, they're bored. It really becomes a job. And to be involved in education, you get that additional intellectual stimulation. It really makes you want to get up at 5:30 every morning and come to work. Pearl 14, consider mission work. So many impoverished people have disabling arthritis and no access to care. And I promise you, I am a heck of a lot better surgeon from all I have learned on mission trips. And you showed the case that Dr. Brown's that he did so beautifully. You're not seeing those every week, because in America, people have access and they don't get 25-degree, deformities. And ours, I started Larry Dorr. I knew I wanted to do mission work. I checked with my church, and it was a 3-month or a 6-month commitment. A lot of it is orthopedic trauma. I haven't put a rod down a broken femur in 25 years. And so I asked Larry, could I go with you on a trip, which I did in 2002, and I was there 48 hours. And I am going to start Walk Denver. And I can't tell you, the weeks of mission for me are the most exciting weeks of my orthopedic life. Pearl 15, when you suffer a complication or your patient suffers a complication, make sure that you suffer. It's good to lose sleep over a complication. Those who tolerate complications well will have more of them. And when you have that complication and you're on rounds, that's the last room you really want to go in, because you feel so bad about that complication. Tom Mallory always used to say, that's a patient you round on 3 times a day. You need to go ahead and let them know that Tom always said, you round on them 3 times a day, you get every doggone consultant in the hospital to see them. So they really know that you are doing everything that you possibly can to help make them better. And one of my toughest complications I ever had, and it was a neurosurgeon's mother, and it was in 2015, and I was messing around with this direct superior approach to the hip, and I had my only femoral nerve palsy of my career, and her nerve was deader than a doornail. And at 3 months, it was deader than a doornail. And I called her every week. And every 2 weeks, I called her son, who was a neurosurgeon at the University of Louisville. And I'll tell you, those were really hard phone calls to make. But that's what you do. And in a year, she has 5+ over 5 quad strength. I was blessed on that one. But when you have those sort of things, you want to put it out of your mind when you really need to crank it up in your mind to help take care and rectify the problem. Pearl 16, I'm just about done. Be honest about your complications. Don't deny them or hide them. And I love this quote from Tom Farron. If you mess up, fess up. And I really think that's important. Discuss them with your colleagues. Get those consultants. Those that say they rarely have complications are either lying or they haven't done enough cases, because all of us have experienced them. Pearl 17. In the pre-op holding, I always, when I'm leaving that room, I've marked their leg, look the patient in the eye and tell them, I am going to take good care of you. And I say that to every patient. And I cannot tell you how many patients have told me, when you came in and saw me, I was so nervous, because pre-op holding is a high anxiety place for them. Many have never had surgery. They don't know what's going to happen. And boy, Dr. Dennis, when you said you were going to take good care of me, all of my pressure went away. So that's a good thing to go ahead and do. And operating on someone is a great responsibility, and you need to treat it as such. It's a time to focus. Talk about what you did over the weekend and how good the snow was when you're closing, not during the operation. And I encourage everyone in this room, and Nicole, I will make you do it, is before you go to the scrub sink, just walk to the head of the table and look at that patient's eyes, and they're closed. They're helpless, they're paralyzed from here down. And they said, Dr. Quinlan, I trust you with my life. And that is a very important responsibility. And I just encourage you, before you go to the scrub sink, I do that periodically, helps keep my mind focused, where it should. Pearl number 19, be kind and fair with your staff. I recommend you be a pleasant yet persistent pest. If things are not right, you never let them slide. There is some truism to the squeaky wheel that is the one that gets the grease. And so, like all of my total knees, at night for the first couple of weeks, I keep them in a knee immobilizer. Most doctors don't, but flexion contracture is, a problem in the first couple of weeks. And if that knee immobilizer isn't on at 6:30 when I'm rounding with the patient, I just very kindly will go ahead and find the nurse and say, hey, I noticed my patient didn't have that on. Was there a problem? Do it in a very nice way. Well, no, I forgot to do it. And I said, well, that's important. And I promise you'll never forget again to make sure that's on. But do it in a kind way, but don't let it slide. Give a pat to all your staff when they are doing well, and a gentle kick in the tail when things aren't going well. Because remember, you want to be their friend, you want to be liked, but what is your big responsibility? Your responsibility is to that patient. Pearl 19, take good care of your patients. And I've had the honor of operating with Sir John Charnley in England when I was a resident, and my 2 mentors that I've already discussed. And when I was with Professor Charnley and I was a second-year resident, I asked him, Professor Charnley, what is the key to your success? And what did he say? Take good care of your patients. So when I was completing my residency, I asked the same question to Tom Mallory. And when I completed my fellowship, I asked the same question to Matt Clayton. And this is the honest truth. I got the same answer for all three of those legends. Take good care of your patients. So in summary, you are entering an exciting new phase of your life. I encourage you to work hard, give every patient your best. There are many rewards that await you, and I wish you the best. And I'm just showing this picture. It's an old picture. There's a lot more on there, but I walk by, we call this the Wall of Fame, and every one of our past fellows, we're now down on the third row, and I walk by that every day. And I know that any of them will take a bullet for me, and I'll take a bullet for them. And to get involved in education throughout your career is very rewarding. And so I'm done. On the left is Lila, and then Jordan, and then Annabelle and Taylor. It's an old picture. Taylor on the right is now 15 and is driving me around with her temporary license. So hopefully those are just things that I've kind of learned. Hopefully that'll be of some value to you in your careers.
Wonderful, Doug. Thanks for sharing those pearls with us. I think it's clear to everybody why so many of us who are coming up in adult reconstruction view you as a true inspiration, and we appreciate those words. Any questions at all from our residents or fellows about some of those pearls? Wonderful. I know people have to run off here and get to clinic or get to the operating room. Before we do that, I wanted to thank you, Doug, again for coming to visit with us here in Charlottesville. We've got kind of a swag bag for you here. We've got various things in here, including UVA hats, so that when the Buckeyes are playing the Who's, you'll be able to put this on and cheer for
I
good
promise.
guys.
Thank
We'll have
you.
Nicole keep tabs on all that, make sure that all the gear gets worn at the appropriate time.
Hey, I'm a big supporter. I root for your guys, and particularly you've had such a good basketball team. National champions.
Oh, yeah.
3-4 years ago. Yeah. Yeah. So other than that team up north, I'm supportive of most of the other teams as long as they're not playing the Buckeyes.
Well, thanks, Doug.
But
Thanks
thank
again
you.
for
This is
coming.
very kind.
Excellent job. Thank you.
Thanks.
For those that want to stay, and I know Trey, you had a question, I have a few as well. I think we've got a few minutes. If you want to stay and hang out, we can maybe do a few more of the spinopelvic questions. That sound fair? Right, perfect. Trey, you want to kick us off as people sort of filter out here?
Yes.
Thank you.
Yeah.